Thanks so much, Maria, for the invitation to come and speak about the efforts around community engagement to advance health equity across New Mexico. So this is what I'm thinking we're going to discuss today. I was thinking a little bit about what the concept of health equity is. We're also going to go through the notion of what a syndemic is, which, as you know, we have a pandemic that it's about to end from an emergency, from a public health emergency point of view. But what this has to do with syndemic. Also think a little bit about the community-based participatory action framework as the framework we can use to mobilize communities and engage them. And then talk a little bit, at least two of the principles of collective impact, the backbone organization and the common agenda. And then we're going to apply that to the state health improvement plan as well as to the statewide referral system, which is a project where we hope it's going to end in benefits to the New Mexico community. But before we start going into concepts, etc., I like you to be engaged with this presentation. And one of the things I'm going to ask you to do is either you can go to slido.com as you have on your screen, slido.com, and when prompted, once you're in the website, you'll be asked to enter a code, and that's the code you have to enter, 3335368. The other way in which you can join is by taking your phone and put your camera around this QR code, and the QR code is going to take you to Slido, and then there you can enter that code, which is 3335368. So let's just wait for maybe 10 seconds and have you all go in there first of all, and then give me a thumbs up. You can give me a thumbs up through the Zoom if you are able to do that. And I see Enrique is already doing it. Thanks so much, Enrique. So great to see you here. As always, it's great to have you in the audience. Beautiful. I see many of you who are already starting to do this. Excellent. I'm just going to wait 10 more seconds, and then we can go ahead. So as we wait, these few seconds to let others join, Mario mentioned, that I chair the board of directors of a non-for-profit here in Nicaragua, and actually I'm standing here in Nicaragua today. This is our annual board meeting. This week is when we have it for this year, and behind me are actually the books of a small library in a very small rural town in Nicaragua called San Jose de los Remates, where our organization serves by training community health workers to bring access to rural communities that have no other way of accessing a doctor or a primary care physician. They would have to at least walk about 3 hours or take some public transportation if they're lucky, which would take long as well to come to the primary healthcare. So I'm sharing this because, in the end, the next question, which is what's going to be in the next slide, it's about what do you care about? Why did you join healthcare? Why did you join public health work? And in my case, I remember actually once I graduated from medical school, I did social service here in Nicaragua, and I was taken to a rural community, and I just saw patient after patient after patient. And I remember thinking, well, I'm really doing nothing here. I'm not able to address the actual needs that the patients have from the social points of view, which actually were the causes of most of their chronic conditions or their or whatever event they were presenting to the clinic. So it really was this connection with the patients and knowing that there was more to be done to address their needs that led me to a more administrative public health path as opposed to a clinical path. So that's my story, but this is yours. Now that I think most of you are in slido.com, tell me, why did you decide to work in healthcare or public health for that matter? Let's see. You will be able to see the answers as you're typing it, and hopefully it'll be inspiring to you too as well. And I see 3 or 4 participants are starting to do that. And you can always, if it's difficult for you to use Slido, you can always add it in the chat, right? Awesome. So wow, this is impactful. So you guys are here because the big word that is coming out is health, which I understand or interpret as how can we ensure that people have the ability of being healthy, right? Wow, look what changed. People at the center. For a second, the people was at the center, right? Like, and this is so cool. Look at this. Like, you have some people here who are following in their parents' footsteps. Some who are interested in maternal and child health outcomes. Some who are interested in making a difference, right? Someone who's want to find something meaningful, someone personal. Commitment to actually improve people's life, patient advocacy. Wow. So if you think about this, this is really at the center of this conversation. What is it that you care about? And how do you use the power that is within you to actually improve systems in your clinic, in the place wherever you are, in your public health office, in the non-for-profit that you work for? If you are working for a non-for-profit, I think most of you are residents in your own residency program too as well. And as we think about becoming empowered to do this, having the ability to change things, then this is the whole point of working with communities too. How do we empower others so that they themselves can reach all these words that you have placed here on the screen? So if anything today, that's one of the big things that I like to take you and inspire you to think about the inner power that you have to do all these things that were the reasons why you got into the healthcare in the first place. So let's start with a little story, which is, of course, it's a fake story. It's not a real patient, but I'm very likely you are going to be very familiar with this type of story, right? Aura is the single mother of a 2-year-old Maria and 16-year-old Carla. She recently lost her job and is struggling with supplying the basic needs for her family, such as food, transportation, housing. So as a result, she has become depressed. Her blood pressure is increasing and her overall health is declining. And she is seeking health care in the clinic where you serve as the primary care physician. So this is my next question to you. I mean, you probably have been on this, like as a resident or as an attending. You probably have been in the shoes of someone who has to support her. Tell me, like in reality, how as a physician can you help her address her needs? And it's okay if you also want to write about the limitations that you may have to hear, right? Beautiful. Listen, that's probably, yes, one of the most powerful things that we can use or do. Team-based care and referrals, right? As you guys are typing these answers here, and take a look at the screen, connect her with local service providers, referral to resources, trip symptoms. Think about like our clinics, our FQHCs across New Mexico, even hospitals, and think about, do we really have the systems in place to be able to connect her with local service providers, to give them resources, to refer her to the places where it can solve her needs? Do we have that kind of system here in New Mexico? I see 2 more participants typing, so I'm just going to leave a few more seconds. So one of the examples today that we're going to be discussing is this idea that I think we have an opportunity in New Mexico moving forward to try and do what you are writing on the screen in a systematic way, in an organized way, and hopefully a statewide way as well. That would have the people at the center and communities at the center, as well as the community-based organizations that connect with the healthcare system. So we're going to give that example of the statewide referral system in a few minutes. Thanks so much for answering that. This is the last question before I actually start sharing some concepts. But what is health equity? And many of you probably have already read many definitions. Community resources. Yeah, how do we provide the community resources to those who need it the most, right? Excellent. What else is health equity? having access to what you need, perfect definition, right? Like, and particularly, it's not about equality. You know, I may need things that are different than what Mario's needs are. Language accessibility, absolutely. How can we provide services, appropriate services, if we don't have language accessibility? Dismantling disparities, giving everyone a chance for health. That's powerful, right? It's about how can you ensure that everybody can be as healthy as possible. Thank you so much. Yes, absolutely. So we'll do another 10 seconds to wait, like for these opportunities here, and it's about how do you balance bringing opportunities to those that typically don't have them, right? So that they can have a better outcome, healthcare outcome, but life in general. I'm going to move on just for the sake of time. So this is not a definition of health equities, but it should be in a way. You know, like we typically use the Robert Wood Johnson Foundation, which is in the next slide, and I won't spend too much time there. This is actually a picture of the Franklin Delano Roosevelt Memorial at the National Mall in Washington, D.C. that I took just about like 3 weeks ago. And I love this phrase because, you know, it really encircles what like health equity is. The test of our progress is not whether we add more to the abundance of those who have much. It is whether we provide enough for those who have too little. How can we bring people up, right, that have less opportunities, different kinds of opportunities? I'm not speaking only about health, but in this case, particularly around health, right? So that's the concept of health equity, and like you know, you can read it on the slides too as well. Typically, we use this definition from Dr. Braveman from Robert Wood Johnson Foundation. So I'll leave it there for you to think about that. And Enrique, I love your comment that resource equity comes from equity in power. Yes, it's about sharing the power that we all have, in my role, in your role, to ensure that other individuals in our community, other organizations in our community can continue to contribute. So let's speak a little bit about equity across the state. And this is a slide that I like because I think it's a good example of achieving some positive outcomes on health equity. So I'm going to give you a couple of pointers here, and then I'm going to ask you to, in the chat, write a little bit about what do you see on this slide. So first of all, you know, the title of it is like percentage of vaccination and SVI, which stands for Social Vulnerability Index by county. On this left side, what you can see is the percentage of primary series completed. So COVID-19 vaccination, primary series, 1 dose. On the x-axis, what you see is the SVI estimate. You see that starts at 0, and as it progresses towards 100, it progresses towards 1 essentially, or what would be 100, right? What this is telling us is that the higher the number, you know, the closest to 1, the more vulnerable a community is. The lower or the closer to 0, the less vulnerable a community is, right? In general, as a county. So you can see here, McKinley County, which I hope that some of you are from McKinley County here. And you can think about like the Gallup area, etc. But like in the McKinley County, it's one of the most vulnerable like counties that we have in the state. And then you can see that Los Alamos and Sandoval, given like the financial resources, are one of the less vulnerable, or have a smaller number of a smaller size of population in social vulnerability. Okay, so I've given you a key pointers. Lastly, I guess the last pointer would be that, of course, the size of the bubble, it's about like the size of the county, right, in terms of population. So what you see is Bernalillo is it is our largest, right, like county here soon. So maybe in the chat, if you like to add there, what do you see here in this, like, what calls your attention in this chart? And actually, I wouldn't be offended if someone unmuted and said, this is what I see on this chart. This is what I'm learning.
I do not see Rio Arriba County.
Okay, thanks for pointing it out. Yes, it's probably got cut off because I took a screenshot of the EPI report, but thanks for pointing that out. Anyone else, what are you learning about that, with this chart?
Well, I think you can see the difference between Los Alamos and Mora counties, which were once the same county.
Tell me more. What is the difference that you see? Which Mora is here, right?
Yeah. That Los Alamos with the highest number of PhDs and therefore the most income, right, is over there on the better off side. And the county that they left, is further on, the other side. And you can see how that withdrawal by both race and class probably has a negative impact on Mora.
Absolutely. And also you see the size of the population, right? Much larger in Los Alamos, well, larger in Los Alamos than it's in Mora. Any other observation? Any other brave person that'd like to unmute and say, what do you learn from this chart? And then we'll move on.
Well, when I look at this chart, it's striking to me that the counties that have a higher social vulnerability also have higher vaccination rates for COVID. And to me, that seems to suggest that we, at least in terms of COVID vaccination, we were able to achieve health equity because we were vaccinating those counties that were more vulnerable to infection more frequently.
Thanks so much. Yes. And thanks to everyone who's has been willing to share. And that's one of the reasons why I presented this chart. And I think your comment is spot on, right? That despite the fact that there is a difference in social vulnerability across counties, that even counties that are highly socially vulnerable have had the opportunity of having a high percentage of primary series of COVID-19 vaccination series completed, which it is perhaps a step on towards health equity as we bring resources to the communities that need it the most, as well as, of course, in this case, because it's vaccination to any of the other communities across New Mexico. And I think this actually is a powerful example of what can happen when we mobilize the community. So let me tell you the story as to how this happened. These were the 4 key elements of the COVID-19 vaccine equity plan that we had in the New Mexico Department of Health. One category was the equitable allocation and access, and I'll share more about that in a second. Then how do we as a Department of Health organize and structure in a way that we can communicate also and think about equity, meaning how do we address subpopulations that are the most needed? How do we look at social vulnerability index? How do we look at at the infection rate too as well, to think about the kind of activities and policies that we would do to address COVID-19. Of course, there's community engagement. How do we empower the community to participate in this process? And we are not talking about here the idea that we as the Department of Health comes and tell you what to do, but really how do we engage and invite communities to tell us what would work best for them in their communities, which is what we did for COVID-19. And then monitor and evaluate for equity too as well. That chart is part of one at least of the evaluations as we ask the question. One of the evaluations question is like, are we reaching the most vulnerables in our community, right? So these are the 4 elements of this COVID-19 vaccine equity plan. And I think what's important about them, and I've actually reduced them, I made them more general so that you can think about them as principles that when you are designing a program or an intervention, these 4 components should be part of your program planning as you think about carrying on with your intervention. Well, a couple of pointers here. So this is the Community-Based Participatory Action Research Framework 2 that was adapted from Wallerstein et al. And Dr. Nina Wallerstein is a very well-known CVPR researcher across the United States, and we are lucky to have her in New Mexico. She is in the University of New Mexico. And this is a very, very busy framework that you can see, but I just want to point out a couple of things. The first one is that as you think about the community engagement efforts that I just referred above in some of the key principles of the plan, we had to think about like the context. So what's happening, right? Like what's the social and structural? What's the political? What's happening around us? What opportunities do we have? What barriers do we have to carry on with ensuring that the community would be vaccinated? Second, we have to think about partnerships and processes, and we are not thinking only about like it's not a top-down structure. It's really thinking about like relationships, individual characteristics of the organizations that we are talking to, or even the individuals who we are talking to, the funders, agencies, academic institutions. And then there's the intervention research. I just want to point out that one of the benefits of thinking with this framework as we do community engagement is that in the process, we integrate community knowledge, right? What would work well for a community as opposed to what we think would work well. We also invite them to participate actively in taking care of their own health, thinking about like what empowering means. And also we involve them in decision-making too as well. So, this process that we've done so far around COVID and other processes in the New Mexico Department of Health is far from being perfect. But hopefully, these are the kind of principles that are guiding us as we are thinking about empowering, sharing power, and integrate community knowledge into interventions. And in this case, then the outcomes, I just want to point in this little corner here, the long-term outcomes, which can be community transformation, social justice, and health equity, right? So it's what we strive for. So I'm pointing this framework just so you can start thinking about like context, partnerships and processes, interventions, and outcomes. That's the framework I like to think as we mobilize community, as we work with communities to improve their own health. I want to share just this model. It's the collective impact model, and there are benefits, there are pros and cons. There's much discussion as to which model to use. That's what we do in academia, right? We are always debating about which model is the best. But one of the things that I believe it's important from this model, which has this kind of 5 components, is this idea of having a backbone organization and then a common agenda. So backbone organizations are essentially institutions. Organizations can be a non-for-profit, it can be a government organization, it can be an academic institution that has the administrative ability of carrying on with the work, right? Someone has to do the work in a collective, right? And if we don't have the resources, if we don't establish who's going to do that, typically collaborations don't move forward. You have to have an anchor institution that is able to move things forward. So this idea of a backbone organization, I think it's a principle that is very important to keep in mind as you are developing collaborations. And then common agenda. Now it's simpler said than done, right? Like, and we're going to get to this like example in just a minute, but like, how do you get different healthcare systems, different non-for-profit organizations, government institutions to align to have a common goal, a common agenda, right? That doesn't happen that often. COVID actually taught us, however, that it can be done. And I think that's one of the things that we have learned from this negative event in our lives, which is if we all rally towards one common enemy, to just so to speak, like COVID-19, then we actually can improve or achieve some degree of health equity. And then that's the importance of then thinking about a common agenda. So going back to that, like first slide, CDPR, context, partnership processes, intervention and research, outcomes, and then insert these 2 how-tos as well, think about a backbone organization and a common agenda. So briefly about going back to our chart, like, this is about the social vulnerability index, which it's a CDC tool that has about 14 indicators on socioeconomic status, household composition, minority status and language, housing and transportation. And it could be a good indicator to help you think, are we reaching out the most vulnerable, the ones have higher risk? The other tool that we use to think about that question or answer that question, and I know that these maps are kind of hard to see, so I want to point the blue boxes here on top. It's allocating in areas of high social vulnerability. So we took the SVI, we looked at the map and said, okay, well, let's look at the SVI by county, and then we will be able to then address send or increase access in these communities. Secondly, here is, well, let's look at the spread of the virus. Where is it spreading the most, and how can we increase access in those areas too as well? So by doing that, we effectively did this kind of 4 different type of activities. At the community level, we had the goal of saving lives. So high SVI, social vulnerability, in congregate living settings, and people who were not able to social distance, well, we could save lives there. At the individual level, by taking those 2 indicators, we were able to also identify individuals who are at risk by age, by race, etc. And then stopping the spread, right, was the other area, thinking about the highest rates of community infection, as well as the highest rates of individual exposure risk. So as you can think about this, when I said about the key elements of the, and I'm going to go back to it here for a second, monitor and evaluate for equity, that's actually how you use data to think about where do you intervene, how do you intervene, but also thinking about this principle of engaging the community to, with them, define what actually can work. So this is one of the ways in which we did community engagement. It's not the only one, but it's one. And it is a very busy slide here. And you have essentially on the left, these green boxes, our DOH staff, not only health promotion or equity team, but the NMDOH staff. And then we worked with health councils, which are planning organizations at the county level. And also we worked with community-based organizations, and we worked with community health workers. Actually, over the past year and a half, we've at least hired almost now like 80 community health workers from across the state, as we're trying to increase our ability to not only deploy community health workers, but administer these kind of programs. The main goal here, you can see the top, was to create demand of the vaccine. And through these examples of community organizations, then we work with churches, town halls, clinics, grocery stores to increase that vaccine confidence, vaccine demand generation, and to ensure particularly on those areas that were needed the most. So I think it was a very interesting process of ensuring that there was data to guide our decision making, policy making, but also community engagement to empower communities to support and invite their own community members to be vaccinated. So let me get into the State Health Improvement Plan, and this is also quite a long text, but I encourage you to read it. It was published in The Lancet in 2020, September of 2020, and the title is Offline, COVID-19 is not a pandemic. What is interesting about this is that if you start reading it, it says that we have viewed the cause of this crisis as an infectious disease. All of our interventions have focused on cutting lines of viral transmission, thereby controlling the spread of the pathogen. But what we've learned so far tells us that the story of COVID-19 is not so simple. 2 categories of disease are interacting within specific populations. So this idea of 2 categories of disease is the idea of a syndemic. So 2 different events synergistically clashing with one another, increasing exponentially negative outcomes for the population. So what you see here is it was the infection of COVID-19 clashing with an array of non-communicable diseases, as well as social conditions, right, that increase the negative impact of COVID-19. This term of a syndemic then was coined actually by a Harvard professor in early 1990s actually. But the most important part of this is thinking about the idea that we have to address social determinants of health. Else, we also are not going to just reduce the negative impact as we try to rebuild the community towards the future. In this effort, that's what we're calling the State Health Improvement Plan. And Mario, if you don't mind, just give me a time check sometime soon, so I know that I'm not going to waste all of your times too. But as we think about the State Health Improvement Plan, it's essentially a long-term systematic effort to address public health problems. So the New Mexico Department of Health, it's by law required to do this, a State Health Improvement Plan. But more importantly, it's not just to check the box. It's to think about, just like we did for COVID-19, given the lessons learned, how can we encourage others and engage the community at different levels, not only CBOs, but other government departments, other institutions, healthcare systems as well, to address a couple of what we call super priorities. And we call them super priorities because it's not about like saying we are only going to address behavioral health. We have to address every other issue that exists, but at least it allows to focus around a couple of things, right? So this state health improvement plan, it's about aligning systematic planning efforts. So we live in a health environment. The governor has health priorities. Then we can have the state health improvement plan, which can be built upon cross-sector collaboration, DOH strategic plans, as well as other governments like HSD strategic plans and action plans, effectively trying to align the work that we're doing, just like we did for COVID-19. And where we are at this point actually is in looking at the priorities. So we are taking a look at what is the governor and the legislature willing to fund. It's important that we think about one of those criteria, right? Like, what resources do we actually have? It's not the only criteria. The other thing that we are doing different here this time around is that we are taking a cross-agency, cross-sector approach to developing and sustaining the state health improvement plan, meaning that we are going outside of NMDOH to invite other agencies from the government and outside the government to identify the priorities and jointly decide on what are the strategies to do that. We are partnering with already like many of the collectives, for example, the Primary Care Collaborative, Behavioral Health Collaborative, to not recreate the wheel, to not recreate other collaborations, but again, align them. We are using data from community health assessments. So many of the hospitals that are non-for-profit by law are required to do community health assessments and invest dollars in the community. That's a law since 2008 when the Affordable Care Act took place. So many of the hospitals are doing community health assessments. What about if instead of everybody doing community health assessments in parallel, in sometimes competing, we define a cycle where we can all together assess, but more importantly, focused on action. So we're gonna like develop goals, solicit public review. We have already done quite a bit of this and continue to engage the community in this work. So these are the different agencies that we have invited in this process already. You can see there are state agencies. There are like health councils, like I saw Enrique earlier today, who is in Bernalillo Health Council, the executive director, and has participated in this process. Also the delivery system, tribal governments, and community populations. So it's trying to invite everybody to essentially arrive to this quote that I love is, a community that knows what do they care about it's powerful community. It's a powerful community. So we have about 3 different phases for the state health improvement plan. We built the foundations, we tell the community story, we are thinking about continuous community improvement, and then like the strategies. I'm gonna go into this telling the community story, and my apologies for, it seems that this slide kind of went a little bit off. But we are using, I just wanna point to you that we're using this framework called mobilizing for action through planning and partnerships. And what's important about this is that it helps you think about a set of criteria to think about the strategies as we engage community. One is a priority. Let's speak about, just as an example, behavioral health. We know that we have one of the highest rates of alcohol consumption in the country. So do the community care about this, right? That's one of the criteria. Do we have data that supports that? That's another criteria. Do we have resources, like and this framework calls it forces of change? Do we have resources to address these issues? And we are looking into what budgets is the legislative cycle leaving us with to address alcohol, for example, and many of the other issues. And finally, what other opportunities are there in healthcare systems that are willing to invest? So telling the community story is very important. And we actually recently, about a week ago, had our first participation session, and we'll have an initial strategy session in about a week. For sake of time, because I also want to engage you a little bit, and time is running. One of the issues that has come up in the State Health Improvement Plan is the inadequate coordination and access to social services that exist, right? Think about the story that I shared at the beginning. A mother of 2 who recently lost her job and is actually struggling to make ends meet, right? How do we connect her? So there is this hope that this idea that we could, like a couple of other states have done it already, deploy a statewide referral system that could be connected to electronic medical records and follow up the actual outcomes of patients too as well. So let's speak about Maria again. We would know that if she was able to find food, we would know if she was able to find transportation, or was she even able to join Medicaid? Sometimes it's even hard for people to understand how to enroll in Medicaid or any of these other benefits that they could. Now, this is easier said than done too as well. I think we also have to think about what are the administrative structures in our different non-for-profit organizations, healthcare systems, hospitals, right? Like care coordinators, facilitators, navigators that need to be in place for this kind of system to work. So it's not only about a platform like an online or some kind of software, but it's also thinking about the layers of the administrative layers that would actually make the system work appropriately across New Mexico. However, I think we have an opportunity. So let me go back to the community-based participatory research. I like us to think a little bit about in that framework. So let's think about the context, and I'm giving you some pointers here. But the question is to you, and I would invite you to unmute and answer this question. What opportunities do you see in the current U.S. and New Mexico context? So let me read the bullet points as you guys are thinking what opportunities you see in the current context. The first one is that we already have a county-wide referral network example with about 65 plus CBOs. That's in Santa Fe County, and it's called Santa Fe Connect. So there is an in-house example. Also, UNM and Presbyterian and a couple of other healthcare systems are already testing some referral systems. And by timing, but just by chance, the system that they were testing actually was bought by the same platform, becoming essentially putting these two large organizations on the same platform. The Primary Care Collaborative is actually an initiative of the legislature, which its main goal is to hopefully increase access to healthcare across New Mexico. But one of the things that they have suggested is that they would like to implement a closed loop referral system, which is this referral that I'm talking about also could have a component of a closed loop referral system. And there are definitions here. We're not going to get into that, but they are also interested, and they actually receive funding from this legislative cycle. In the US in 2022, CMS approved the first measures to track social determinants at federal level. So, which means that by law now, hospitals they have to screen for social determinants of health. So how do they do that? And what do they do with the information is actually the issue that hospitals are, not the only one, but one of the issues that they are most concerned. And then in the United States, there are at least a handful of examples of statewide referral systems, and there are more examples of countywide referral systems too. So to all of you who are participating here today, thinking about this this CBPR framework, what opportunities do you see in the current US and New Mexico context? All right, I'll tell you that, Enrique, go ahead.
Yeah, I think the context is people are feeling like things in public health are politicized, and I think that creates opportunities for conversations to get people involved.
Thanks, Enrique. Thanks so much for unmuting and sharing. Yes, I see an opportunity to mobilize community as well as government, as well as non-for-profits and healthcare systems towards a statewide referral system. Long story short, we actually have already a partnership, and this is the next slide. Who would you invite to collaborate? And because of time, I'm going to tell you. We have a steering committee that is actually formed by community-based organizations, representation of the community-based organizations, government departments such as HSD, NMDOH, Behavioral Health Collaborative, and BHSD, which is a particular division within HSD, Human Service Department. We have representation from healthcare systems, a couple of other government agencies that see the ability to do this. Long story short, I think there's this current opportunity that we have to together have a common agenda and think about, a backbone organization. We actually are in the process of thinking about who is going to be that backbone, that financial administrative body that is going to move this along. And at the same time, how do we continue to build this common agenda, which is going to include actually talking to all of these partners that I talked about, like community-based organizations, government, healthcare system, the users of the system as well, so that we can build something that it's what they want to see as opposed to what we think we need. So what outcomes should we seek? I think it's, I just want to take you back to this idea that health equity, social justice, it's our end. It's how do we improve the lives of people in our community. So hopefully throughout this presentation, you grasped a couple of concepts around health equity, the notion of a syndemic, and why do we need to address social conditions. Also, the principles of community-based participatory action, as well as collective impact principles, and at least an update on where are we at with the state health improvement plan, how can we use it to mobilize community across the state to address a set of priorities, and this example of the statewide referral system. So, hopefully this was useful to you, and I'll send it back to you, Mario, and thanks so much.
All right. Do we have any questions from the audience? You can either ask in the chat or go ahead and unmute.
Hi, this is Caitlin. Thank you, Roberto, for that presentation. I was just thinking about, your question and the thought of, the drivers of this work, which is community health workers, and thinking about how, in that context, how we're working to sustain that role, where that funding's coming from, because I'm sure there's many on the line that know, it's really hard to we're seeing the value and we're being told of the value of a community health worker, but as far as what that funding looks like and where it comes from, that's kind of lagging behind in a way. And so just thinking about that, because they really drive this work. They're doing a lot of work on the ground. And so I just wanted to mention that.
Absolutely. And a couple of great news. One is we're working with Medicaid to amend the state plan, which would allow for community health workers reimbursement. And according to the Medicaid medical director, we think that by at least July or August, that should be amended. That's not the only part of it. The other part is that we are working with a couple of partners, Community Health Workers Initiative, as well as our own Office of Community Health Workers, in developing a team that can support healthcare systems or hospitals or FQHCs that are not able to or have not administered community health workers to learn how to do that, because there's quite a bit of that administrative piece, and how to evaluate that. That's been helpful to as well. So a team that can support others, institutions also in deploying community health workers and administering too. So we have those two pieces as well. And then we're trying to identify other fundings of sources in addition to Medicaid, because it has to be a multiple sources of funds. Thanks so much. Yes.
All right. Any other questions? Dr. Martinez, thank you very much for joining us today. And if there are no other questions, we will go ahead and end the session.
Thank you.